I grew up in a farm setting, so death itself became something that I became quite familiar with, certainly with a lot of the animals that were on the farm. But my first real graphic focus of death was what I call losing my brother, which was in fact actually a blue heeler dog. So at 7 years of age, he'd been a puppy when I was born. We grew up together, and at 7 he was shot and killed. And that was probably one of the most shocking childhood memories that I actually have. When you're living in a farming setting, death is an inevitability. You see animals get old, like say your farm dog or someone else gets old and they're actually put down because they've reached their utility, or if in fact if it's a horse or some of your cattle. But you're always seeing a lot of the stock turning over to go off to market, and you experience the killings that occur in abattoirs and the dressing of meat. It becomes a sort of a normal type of activity in that sense. So it does sort of make it normalised in the animal side of things. And when it comes to humans, it's a question of that's a little more affronting because I think people in my generation, death of children, death of relatives and others is actually not that common. There's a lot we need to do around death. One of those is, I guess, because of the success of modern healthcare, modern public health, particularly in the developed world, death has become something very unfamiliar and something that is not even expected to a large degree. Is that I think most of us are now starting to think we might be immortal because we are living for quite a long time. Go over to the developing world and we know that there's such a high rate of children that actually die, and then young adults that actually die from a multitude of things, and a lot of people don't reach anything more than say 45 or 50, so a lot more familiar in that setting. Now, unfamiliarity means it's unfamiliar for the general public to expect, well, what's going to happen to me? And when you tell someone, when I was a GP, and you tell someone that this is a serious disease and we'll do our best to make sure we can try to bring it under control, but it's almost certainly that this is going to take your life, that's a shock. On the other side of that is a lot of the clinicians, death is not as familiar because it's not as common as to what they see. So they too actually deal on a personal level, but on a professional level. So one of the biggest challenges that we actually have is understanding that death is inevitable. Also, the other part is that it is in fact a natural progression of life. And how we deal with this and how we face this is compassion, empathy, I guess caring and love, because as a clinician, those are the parts that I actually got back from my patients and the journeys that they let me enter into. And it's some of that our society has lost. Yeah, one of my passions that I developed from a public health and a clinician perspective was, I guess, the absence of expertise in the care of the dying. I was involved in a project looking at the quality of care that was getting into the rural hospitals in our state. And one of the alarming things we found was that many people were not getting appropriate pain management or symptom management. And that was really because the clinicians and the caring teams didn't actually have the skills. And so people were suffering. Healthcare is a lesson in inequity, and we know that where you live and the community you live in really makes you the person you are, or in fact actually it's like the cards that you were dealt. And your journey is going to be tougher and harder if you haven't got good housing, education, access to fresh, clean food and running water and clean air, and access to health services and preventive health checks and even early interventions and care. And that really does spell it out. And we see those differentials. They're quite profound. I guess in the rural areas and in the dying or the remote areas is if you don't have palliative care expertise, you get what you get, as opposed to, say, if you're in the centre of one of our large cities. So when I was doing my PAL care training, I'm a solo practitioner. I've got a hospice nurse that I can use to help me, which was fantastic, but many rural doctors didn't necessarily readily have that access. And when I started the training, I suddenly found a new friend who was the regional PAL care physician, but he was still 2.5, 3 hours away, but he would take my calls any time of day or night. And I was always there as, the phone a friend to actually help me through a situation and provide guidance. I went down to do some training in the large hospital in the city, and we're sitting there in this room with 22 people doing case management. And I was asked to comment on this and by the professor of Pelcare, and I said, look, I'm just reflecting on this. When I'm sitting in my multidisciplinary team of 1.5, and they all burst in riotous laughter when they realised, you guys have really got it here with 22 people to bounce around the ideas and follow that. That's why they're a centre of expertise and excellence. And that's why we're really just getting by with the skin of our teeth with small teams. Go further out into the remote areas of Australia, and access to service is a major problem, let alone access to expertise. We've got a long way to go. We actually instituted a major program across the rural areas to try to actually lift that up by training the clinicians as teams on how to recognise and deal with the death process in a much more compassionate and caring way, which was actually more effective in the way of helping people relieve the symptoms. And that to me was actually an epiphany to have some great trainers and leaders to actually help me in that process, because one of the most frightening clinical situations that a primary care clinician can get into is someone dying with profound symptoms that they can't control and they can't manage. And that feeling of helplessness, I can't do anything, is in fact actually earth-shattering as a clinician, let alone for the poor patient. My early experiences and exposure to death, and also through my early career and then also from personal levels, have all been learning experiences on where death fits and how it is. We knew that all of these doctors would have different perspectives, one from a personal perspective and two from a cultural perspective about death and where it is, and not understanding that in the Australian system that there is expertise in palliative medicine. We set up a way of actually running through that, so I'd first get them to tell me their story of where death fits in, what death means, why are you here in the country, how did you get here, and the journey that on that point. And then I'd actually do a humbling story about circumstances as a clinician where I was challenged by someone's dying process clinically and how that was a problem. And that would then open the floodgates to stories that in some cases were alarming and other cases were just, frankly, they're in the same boat that I am. And as a measure for that project, we used an increase in referrals to the palliative care services as an outcome measure, because we couldn't measure the quality of deaths. And we saw a rapid uptick in referrals where that previously weren't occurring, which meant that then other experts could come in and assist them in the clinical process and guide them through it. Many of my clinical colleagues have a lot of trouble accepting that the best thing you can do now is care, compassion, and start to withdraw what we would call futile active treatments in certain phases. Some of that is, well, who's actually a doctor? So to get a doctor, you've got to be pretty sort of focused on getting your study and your grades, and things go where they go and they work when they work, which makes you a bit of a perfectionist. And if you view death as being failure, it's often a hard thing to look at a personal failing. This persists, and it certainly is something that actually, again, needs to look at personal development of the caring and the caring professions in that setting. I guess the perfect system for us would be a way of, in fact, actually looking at training that allows people to actually understand it's not failing if your patients are dying. Palliative care physicians are a classic example of this. Every patient they have dies. There's always this tension as a clinician of, am I doing the best for the patient? And then looking at, well, who's making the decisions and how am I making my decisions? So futile treatment itself is, I guess, the idea of, in fact, actually continuing on and on and on with therapies which are not actually going to be doing a great degree for the longevity of the patient, and probably also adversely affecting the quality of the remaining life they've got. And sadly, I've seen many examples, certainly as a junior doctor, of seeing oncologists in particular. There's one oncologist I remember who just could not accept or ever give up on his patients. And even seeing him sort of, I guess in one sense falsely, in retrospective analysis of this, falsely saying to the families or even the patients themselves that we've got this new drug and we're going to try it on you, and making them awfully sick and ill towards the end. I've certainly seen that, and I think in one sense maybe an improvement in the sort of the system there would be to say that when we're moving into these areas we do need to have case discussions, and that's what good units do, rather than to have lone operators that are actually treating for why are we doing this. We are almost certainly over-medicalising the end of life as it stands. And some of that is, one, the medical profession's problem of death as being viewed as a failure. So I'm going to continue to do things. And I have certainly seen that in some of my medical colleagues of actually over-treating people in the dying process. And without, in fact, actually even talking to them or their family about, well, hold on, what are we actually doing here and why are we doing this? For whose benefit? And it's quite questionable behaviour in that setting. On the other side of it, I've certainly seen families responding in the way as you have to do everything for mum or dad. Well, we are doing everything. We're providing care, compassion, love and symptom relief. Oh no, if they need an operation, we need to do the operation. If they need this treatment, we need to do this treatment. And I've seen that behaviour as well. Some of that's ignorance or fear or false expectations. So performance indicators for death are difficult, obviously, because the person that you need to ask is, hey, how was that, has gone, and they can't answer that. But one of the projects that I was looking at were clinical indicators for the process. So in this palliative care process in the aged care settings, we're looking at, well, what are some of the quality metrics that we could consider? So I started testing a few of these measures, such as interviewing the staff. So personal care assistants have not been trained in a lot of clinical care, but a lot of care. And asking them, tell me about it. What happened? And so looking, say, for, in one sense, sort of subjective measures about, well, on a stress level, where were they fitting? Did they feel that they were actually in control of themselves and also doing something meaningful? And then from the clinical staff to actually look at the idea of measures of control or helplessness, and looking at those things. Didn't get far enough to actually quantifying those, but I do think we do need a system of measuring how did that work. On the family perspective, how confronting would it be if I was to ask you, say, after the death of a loved one, how was that experience? What worked? What didn't work? What could we have done better? What did we do well? We don't ask those questions but we should, to actually feed back so that we can continue to improve where it was. I mean, the sort of clinician I am, I was always balancing those things inside of my head as, well, how did that go for me? What did I need to do better? And where did I actually not do as well as I could have? But I'm not aware in this area that we have got full measures that are actually helping us with that process of quality improvement. I'd certainly say that there is such a thing as a good death, but then it's good on whose reflection? On mine? Okay, I could say from a clinical perspective, the family were in fact actually assisted through this incredible phase. They were able to ask a lot of questions and their questions were answered. They were able to spend a lot of time with the person. Most importantly, on the patient side, their symptoms were controlled adequately enough for them to maintain as much composure and presence of mind as they move through that area. I've certainly treasured experiences where I have seen this, where people have been able to have that right to the end and knowing that it was certainly partly to me and partly to the circumstances of other carers around them that actually have allowed for them to actually have those final moments of really deep, meaningful experiences for everyone involved. The spirituality, I think, the issue of the spirituality really comes into your own personal values. So I'm an atheist, and I guess in one sense for me, people would say, well, how do you actually respond around death and thinking about, well, where might we go in the higher order? I suppose in one sense, I view death as a natural progression about where we're going, and certainly when you see people suffering, it's a conclusion to the suffering. If the person is spiritual, I'll go with it. And certainly involve myself with whoever across their religion needs to be involved and engaged with the passing process that they're actually in. I was reflecting on the stages of grief or of death of someone moving through there and true acceptance. As a GP with 25 years of clinical experience, I never really saw what I would consider three people who had true acceptance of where they were going. And they were all religious, deeply religious people. In fact, one of the women, she had a set of angel wings on her wardrobe and said that there will come a time that I'll be putting those on. Now that's fine, I can go with that. I'm not going to dispute where your spirituality is. And in fact, it was actually really moving. We don't know what our loved ones think. We have no idea until you've asked them those sorts of questions. And if you don't know what they want to happen when they're dying. So there are many aged people who would say, please stop futile treatment. Let me be in peace. I want to go home, and you won't know that unless you actually ask. And the most important people to ask is family members asking around those, because then there's no shocks. You know, Mum always said that when she got to a certain point in certain situations, say like she started to lose function in her body, she started to lose her mental capacity, she just wanted to be out of pain, and she wanted the grandkids to sit around and just be in the room with her. And if that doesn't happen, we haven't served her right, have we? But you didn't know she wanted that until you actually sat down to talk to her about it. So end-of-life planning or advanced care directives is something, or a new concept for so many people, but it has been established now, certainly in the Victorian setting, but even in the Australian setting, for probably a decade or so. It came from a lot of the research that was done in the Veterans Affairs system in the US, so it was certainly trialled. And one of the projects that I instigated in our rural area was how to apply advanced care directives into a setting. So one, the carers actually have to learn, how do I broach the question with someone? So I'm 55, and you're telling me you want me to do an advanced care directive? A lot of people won't do it. Now 55 is probably a good time to start thinking about, well, what would I do? And talking around to your loved ones, it doesn't have to be as definite as, say, someone who's at 85, who's got a life-threatening illness, about where, what and how would I want things to progress? How active would I want the treatment? When would I want treatment to settle down, to give me digging? Who is going to make those decisions? So who's going to be the medical power of attorney for those things? It's important we do this, because it's about as important as planning for your working career through to your retirement, through in the financial perspective, is what are you going to do? Because sometimes these questions will come at you rapidly from left field and you're not expecting them. System challenges that we have with regards to how death is managed in our care systems and its journeys are probably best to look at it on the types of journeys that you might have. So let's pick a cancer that's common. Well, let's pick bowel cancer, for instance. It's the commonest cancer killer in this country, and people don't know that. They always think about breast and prostate or something else, but it's bowel cancer that is the problem. Caught early, you can be cured, or you can get a long remission period with regards to bowel cancer. Caught late, you will die from metastatic disease through your body. So let's think about your care one. First, someone's got to pick it up. Then they've got the handover that occurs to you to go to the colorectal surgeon, who may or may not then hand back to the primary care team, depending on the stages, or may hand over to more specialist cancer services, and then you get lost in this mire of cancer services. And when do they send you somewhere else, who then actually looks at the next progress of care? Now, when things work well, patients and families don't realise that they're working in a well-oiled system. When they work badly, you get caught somewhere, snagged somewhere in that system, and you start getting care that's probably not what you actually need. That's the system and the system failure. That's what we actually need to look at to try to correct this, for people engaging with teams as they move through. COVID-19's been a slap in the face for the global population, thinking about how we were infallible almost in one sense. We know the Spanish flu had an estimated 40 million deaths across the world back in the 1920s, 1930s, which was an awful significant number of population and definitely an under count. And we've also got these sort of undercounts now of the death rates of COVID. So as we stand now, it's well and truly over 15 million people in the world have died from COVID. But not everybody has actually been touched by those deaths, so they still don't believe how serious this disease is. So that's again the denial that occurs there. As for my colleagues in the intensive care units and across the wards and the aged care settings, there are many, many damaged health workers who have not only experienced substantial numbers of deaths over a short period of time, but they themselves have probably contracted the disease and still have ongoing symptoms. So I think COVID itself has definitely changed the way the health sector will view death and dying if those health workers can actually come back. The pandemic has shown us that palliative care has a significant role to play in acute disease and acute disease outbreaks. So suddenly we've got all these teams working together and making these decisions quite rapidly that somebody with severe COVID is just not going to make it, and we actually have to look at the idea of taking life supporting machines off them so we can put someone else on it, because that person's not going to have a good outcome. Those decisions are and always will be tough decisions to make, and they were made even harder during COVID because family members were all doing this remotely and calling the shots, probably not being in the room to see how ill their loved one was. From a public health perspective, palliative care is good clinical care, and it's something that should be part of a whole care system. So many countries don't have the luxury of having palliative care, and so many places, even in Australia, don't have the luxury of accurate expertise in the sense of palliative care for their community members and, basically for anyone who's in fact passing through in the death process. That's a major improvement that we need in the system. So I guess as a clinician, death is something that shapes who you are and how you in fact actually focus on things. I guess as a public health specialist, you're trying to promote well-being so that people can in fact actually be well and have a short period of ill health and illness. Sadly in Australia, we've got a very long period of being unwell because we reach that point and we just grumble on for many reasons. I guess my experiences there are you don't have to have that long grumbly period. You can, like some of my wonderful patients, hit 92 and be well until the moment you die in bed, and that's it. Everybody wants that, but very few get it. So changes, I've looked at obviously training programs and been engaged and promoted in state leadership roles for palliative care training for GPs, advanced care directives looking at the amazing role that district nursing and aged care nurses can actually play in assisting in broaching these questions and bringing those forward. And importantly, looking at drugs and drug supplies and restrictions around those. I think in some of those areas I've had a role in playing in those. And I guess my roles now are more at the idea of not only quality of service across the patient journey, but as in the other one is promoting health, well-being, but then the natural course of opening the discussion perhaps. When you're a resident doctor, you develop very intense relationships with a lot of your colleagues. And one of my mates, I guess, we're in our late 20s, and he got lung cancer. And he died within around about 6 months or so. That was an incredibly sad time because his second daughter was born 2 weeks before he died. And I was in the cancer hospital with him the night before he died, and he wanted to have an arm wrestle, and he was talking about what he was going to do when he was going to leave because he wasn't going to die. So much more personal than when you're actually dealing with, say, a patient and a patient's death, and so confronting. I suppose in one sense you carry those memories of death with you and the implications of that death around what actually happened, how it was diagnosed, what was lost, how lives were changed, how dreams were shattered. But it also showed the mortality that we all have.